And the next speaker is our close friend from the Indonesia, Bambang Darwono, and with the topic of an endoscopic technique for releasing the low-cut facet joint with correct multi-level spine degenerative deformity. Bambang, hello. Nice to see you. Are you ready?
So I start?
Yes, you can start.
Okay. Thank you very much for the invitation. I'm my pleasure and I'm honored. So this is my topic. Endoscopic technique for releasing the locked facet joint will correct the multi-level spine degenerative deformity. We know that aging spine is natural changes of the biomechanical construct of the spine motion segment. The philosophy life is changing and changing is life, including the spine musculoskeletal system, bone, joint, ligament, muscle, peripheral nerve, etc., experienced by everybody and could not be avoided, and leading to a kyphotic deformity. Life is progressive kyphosing event. But what is spine degeneration? Spine degeneration is a pathologic condition, damage, wear and tear, and change the biomechanic construct spine motion segment in the aging spine. Occur at any age but could be prevented and be treated if the etiology is identified. The changes of the biomechanical construct in the spine motion segment might be single or multi-level and lead to a deformity in cervical and the lumbar spine. Three-column damage theory in cervical and lumbar degenerative cascade. It can start from the anterior column, middle column, or posterior column, may suffer alone or together from inflammatory to compressive reaction and change the biomechanical construct of the spine motion segment in single or multi-level and lead to a spine deformity. This already published in 2018. The dynamic movement of the spine motion segment need the natural stabilizer, that is the disc, facet joint, ligament ALL, PLL, and supraspinatus ligament and the muscles. Damage in the degenerative spine motion segment, we call it deformer. Might be osteophyte, hypertrophic facet lamina, spinous process, and canal stenosis, and also flavum infolding and hypertrophy. This is in cervical spine. Multiple disc rupture, ligamentum flava infolding, and annulus rupture and nucleus extrusion. Deformer in Bastrup type 4, oblique abutment, create a spinous process atop across the spinous disc level and lead also to lateral disease and deformity. The normal facet joint is a gliding joint in flexion, extension, and in lateral flexion. What happened in facet hypertrophy? Dislock the facet joint in deformity. So the nature of rigid degenerative deformity is combination of two factors in three column, the stabilizer and deformer. The deformer then dysfunction the stabilizer and lead to instability, then ending with restabilization in rigid deformity. This is the three phases Kirkcaldy degenerative cascade theory. So in multi-level rigid degenerative deformity, there are two options of treatment. Make a spine a rigid segment with fusion, or bring back the spine in previous motion segment. The gold standard, open surgery decompression, and this some way will sacrifice part of the stabilizer, and then we need an artificial stabilizer, implant to restabilize. The question is, if we could preserve this strap and keep stabilizer intact, do we need fusion? Advantage of uniportal endoscopy is a docking system, closed system irrigation, wider horizon of view over the top, preserve the stabilizer, decompression, and remove the deformer only. So the concept of endoscopy in spine rigid degenerative deformity is retain the stabilizer. just remove deformant. That is what we call the first decompression. The result is release the locked facet joint and rigid deformity and regain the stabilizer function, and in some way will reduce the deformity. We call it the second decompression because the best decompression is deformity correction. Normal facet joint, gliding joint, inflection, extension, lateral flexion. Facet hypertrophy lock the facet joint in deformity. To unlock the facet joint, we need to perform medial facetectomy. This is facet hypertrophy, lock the facet joint in deformity. Then we perform medial facetectomy to release lock facet joint and that create deformity like this. So this is inferior articular process. We do medial facetectomy and also the superior articular process, and then we can see the lateral recess already well decompressed. This is the cases. Male 71, rigid deformity. Then we perform medial facetectomy from IAP, SAP, and then lateral recess foramen already released, and also the contralateral side. Before and after medial facetectomy, before and after. Deformity is corrected. No implant. No fusion device. Another case, female 77, facet hypertrophy and lock the facet joint in rigid deformity, like this. Then we perform the same uniportal endoscopy, medial facetectomy, refute deformity, and preserve stabilizer. Before, after, before, after, before, after, before and after, before, after, before and after. The result is deformity corrected. No fusion device. This is another case, female 83 with degenerative deformity. We do the same things before, after, before and after, medial facetectomy, before, after, and this is the X-ray before and after, well corrected, no fusion device. Another case, 55, wheelchair case, claudication, 10 minutes with spondylolisthesis. We perform the same things before, after, corrected. And we can see here before, and after. Another case, this is 30 years pars interarticularis fracture like this, unstable. And 3 months later, severe low back pain and right sciatica. We can see stenosis on the right side and facet hypertrophy. Then we perform the medial facetectomy, before, after. The result, deformity corrected, fracture path reduced. 1 month later, you can see, 2 months later, and 3 months later, no fusion device. Before, deformity correct, no fusion device. Before and after, before, after, and after. No fusion device. This is male 62, worst condition, bedridden tetraplegia due to cervical and lumbar spondylosis with rigid deformity. You can see the left hand only move like this, cannot wake up. The right hand like this, and both leg only move like this. Here we can see the MRI, cervical spondylosis, 3, 4, 4, 5, 5, 6, very severe. And also the lumbar, like this, 3, 4, 2, 3, 3, 4, 4, 5, with deformity. Then we per uniportal endoscopy, decompression, foraminotomy, medial facetectomy, laminotomy, and discectomy, also cervical. This is what we do. It's already well decompression. And also the herniation, we remove it. And the result is before and after, before, after, before, after, before, no implant, no fusion device, and corrected very well, the neck. Then we perform also for the lumbar, the same, before, after, before, after, before, after, MRI before and after, X-ray before and after. Then it start to move. The left also, the foot much stronger, also the right side, and start walking, no fusion device. So take home message, endoscopy is developing instrument for degenerative spine. The concept is how to use it for cervical and lumbar degenerative deformity. First, retain the natural stabilizer, this facet joint, ligament, and muscles. Remove the deformer, osteophyte, and also medial fasectomy to release the medial facet. This herniation and flavum infolding. And this will naturally release the lock facet, rigid deformity, and regain the stabilizer function and will correct the deformity without fusion device. The best decompression is deformity correction. Thank you very much for your kind attention.
Thank you very much, dear Dr. Bambang